Good morning. Hereby, I open this academic ceremony in which Michele Di Mauro will defend the academic thesis, Tricuspid Valve Regurgitation, its interplay with the right ventricle, prognostic role, and surgical results in various settings. May I invite you to present a summary of your study and the conclusions of your thesis.
Thank you. Hi, distinguished prorector, distinguished member of the Corona, dear colleague, dear friends, dear family. I will introduce my research, tricuspid regurgitation, its interplay with the right ventricle, prognostic rule, and surgical result in various settings. Tricuspid valve is made by three cusps. The anterior leaflet is the largest leaflet, the second leaflet is the septal one, and then the posterior is the smallest of the three leaflets. And we have also an annulus, which is ellipsoid, asymmetrical, and is not planar, but cedar-shaped. Tricuspid annulus, moreover, increases its dimension of about 30% in atrial systole and early ventricular diastole. Then we have a subvalvular apparatus made by chordae tendinae, which are fibrous strands between valve leaflets and papillary muscles, or directed to the myocardial wall. And papillary muscles, which are three, the anterior one is the largest one. Even in presence of normal leaflets, we can have functional tricuspid regurgitation, which is due to dilated circular and planar annulus, increased tricuspid valve tethering, and this is usually secondary to left valvular disease, pulmonary hypertension, atrial fibrillation, left ventricular dysfunction, or right ventricular infarction, or cardiomyopathy. In case of tricuspid valve endocarditis, the main issues are vegetation and perforation of the leaflets. It accounts for 5 to 10% of all endocarditis cases, and this is common in intravenous drug user, in patients with pacemaker leads, vascular access, congenital heart disease. The main germ involved is the Staphylococcus aureus, and surgical treatment is required only in 10 to 20% of cases, which are the aim of my thesis. In the first chapter, we investigated the prognostic rule of tricuspid regurgitation, the results of tricuspid surgery in various settings. Then we assess also the interplay between right ventricle and pulmonary pressure in tricuspid surgery. We assess also the very long-term outcome of a cohort of patients with tricuspid valve infective endocarditis. And finally, we assessed which is the best surgical approach for functional tricuspid regurgitation. Going on to the prognostic rule of untreated tricuspid regurgitation, we assess a cohort of patients between 1988 to 2003, 165 patients undergoing mitral valve surgery without treating functional mitral regurgitation. And we divided the entire cohort in two groups. According to the FTR grade, mild or less, and moderate or more, the two groups are quite similar, except for reoperation and type of surgery. We didn't find any difference between the groups concerning early mortality, but when I assessed what happened in the long term, I found that there was a worsening of tricuspid regurgitation in patients with moderate or more tricuspid regurgitation at the time of surgery, of mitral valve surgery. And also, the long-term outcome was significantly different in terms of survival on 5-year possibility to be alive or in 1 or 2 NIAC loss. And this was confirmed also by the multivariable analysis. So in conclusion, leaving untreated tricuspid regurgitation moderate or more at the time of mitral valve surgery could impair long-term outcome. Then we assess with a narrative review what happened in various subsettings, and as you can see, moderate or severe FTR is a risk factor in different group, in patients undergoing left side valve surgery, in patients with isolated FTR after mitral valve surgery, in patients with isolated FTR in absence of left side valve lesion, in patients with left ventricular dysfunction, patient with the pulmonary hypertension. So moderate and severe tricuspid regurgitation is in all these subset a risk factor of worse outcome. But what about the result of tricuspid valve surgery? We found some different risk factors for the failure of tricuspid annuloplasty, such as annular dimension, threatening aids, tending area, preoperative left ventricular function, preoperative tricuspid regurgitation grade, presence of pacemaker leads, suture or strip annuloplasty, residual tricuspid regurgitation, and postoperative pulmonary hypertension. In conclusion, FTR, functional tricuspid regurgitation, is characterized by structurally normal leaflets. The entity has often been neglected, and it was neglected for several years, but the impact on prognosis is clear. And clinical and echocardiographic features should be taken into account to decide between tricuspid valve repair and replacement. Then we assess the interplay between the right ventricle and pulmonary hypertension in tricuspid valve surgery. We enrolled 541 patients between January 2009 and December 2012, and we divided in normal right ventricle and abnormal right ventricle, which means dilated or dysfunctional right ventricle. Then we divided further in each group in 3 groups according to the absence of pulmonary hypertension, moderate pulmonary hypertension, severe pulmonary hypertension, according to the EUROSCORE2 version. So we had 6 groups to compare. As you can see, since the main cause of mitral disease was a rheumatic one, the replacement was uniformly the main choice among the groups. But we decided to replace tricuspid, especially in patients with abnormal right ventricle. No difference was found between patients with normal right ventricle, even in presence of moderate pulmonary hypertension. But we had significant difference when we had severe pulmonary hypertension and when we have normal pulmonary hypertension, no pulmonary hypertension, but abnormal right ventricle. But the worst condition was the presence of both pulmonary hypertension, severe pulmonary hypertension, and abnormal right ventricle. And this was confirmed also by a multivariable analysis. So in conclusion, severe pulmonary hypertension impacts on mortality regardless of the right ventricular condition. Abnormal right ventricle impacts on mortality regardless of pulmonary pressure condition, but the worst condition is the presence of both abnormal right ventricle and severe pulmonary hypertension at the same time. So we investigated which is the best approach for functional tricuspid regurgitation. We performed a network meta-analysis. We enrolled 31 articles, and the main endpoints were early mortality, early, moderate, or more tricuspid regurgitation, late mortality, and the special late, moderate, or more tricuspid regurgitation. We didn't find any difference in terms of early mortality between not performing tricuspid annuloplasty, suture annuloplasty, implanting a flexible ring or rigid ring, as well as for early tricuspid regurgitation, moderate or more. But when we investigated long-term mortality, we found that any ring is better than suture annuloplasty. In terms of late tricuspid regurgitation, moderate or more, rigid is better than flexible, than suture, than non-tricuspid regurgitation. And this is the risk reduction among the groups taken into account as a reference group, no tricuspid valve annuloplasty. As you can see, rigid seems to be the best choice. When we investigated also prophylactic tricuspid annuloplasty, we have only 4 studies, and the pool effect was in favor to perform a prophylactic tricuspid annuloplasty. So in conclusion, in case of left valve surgery, tricuspid annuloplasty is better than waiting approach. Ring annuloplasty is better than suture annuloplasty. Rigid ring seems to be better than flexible ones. Prophylactic annuloplasty should be better investigated with larger clinical trials. Finally, we investigated what happened in the isolated tricuspid valve endocarditis. We choose a group of patients from the Italian Registry for Surgical Treatment of Valve and Prosthesis Infective Endocarditis, the INFECT registry. We had 157 patients with isolated TVIA, 3.8% of all group. In most of cases, patients were drug user or had the pacemaker ICD lead. In 42%, we were unable, due to the retrospective nature of the study, to identify the source of the infective endocarditis. As obviously, the IDVU patients were younger than the other, and the Staphylococcus aureus was the main germ involved. We performed a repair in 49%, replacement in 46% of cases, and in 8 cases we replaced a previous implanted prosthesis due to endocarditis. No difference were found between the 2 groups, IDVU and non-ID user, concerning mortality or major complication, but in long term, patient who is drug user had worse outcome. And this was confirmed also by multivariate analysis, as well as for pacemaker ICD lead, as well as for prosthetic tricuspid valve endocarditis. In conclusion, tricuspid valve infected endocarditis represents a well-known challenging setting. Surgical treatment provides satisfactory results in terms of early or late outcome, but preoperative clinical profile identify patient at risk. In conclusion, we investigate the repair versus replacement. We perform most of replacement with a bioprosthesis, and in most of cases of repair, we use a vegetectomy plus or not patch and annuloplasty. And we didn't find any difference in terms of early or late survival. So probably surgical strategy should be tailored on valve condition. Thank you very much for your attention. I give back the words to the prorector.
Thank you for your presentation. The opposition will be started by Professor Jacobs. He is professor in general surgery in this university. Professor Jacobs.
Thank you, Mr. Prorector, dear candidate, dear promovendus. It was a real pleasure to go through your book. It's not a standard PhD book. And also very nice to see that your passion is not only in the operating room, but also in theater.
Thank you.
You know, some 100 years ago, the operating room was in fact the most perfect example of a theater, in which the stage was filled with supernumerary actors. The main subject was positioned in the middle of the stage. and everybody was waiting for the leading actor, the master, the surgeon to come into theater, and then everybody was happy that the play could start. Well, today should not be theater tragedy, but enjoying a fantastic day, of course. However, not before answering some questions, and the questions will show up in the next 40 minutes. I have two questions for you. I will let you answer the first one and then go to the second one. As a vascular surgeon, I read your book from a different perspective, of course, and I learned that you assessed that the Framingham study showed that the presence of tricuspid regurgitation was 82% in men, which is tremendously high. And I think that cardiologists and cardiac surgeons are really happy that the tricuspid valve now finally gets more attention than ever before, because it was always aortic valve, mitral valve, but tricuspid valve was not significant or not important enough. So that definition in the Framingham study being tricuspid valve insufficiency or regurgitation, is that different than the definition you used in chapter 3 if you talk about a functional tricuspid valve insufficiency or tricuspid valve failure? What is the difference? And it's important because if the nomenclature is not unique in all the studies, it's comparing apples and oranges. So what is actually the difference between functional, and I learned just your list that you need to have pulmonary hypertension, severe leakage, etc. But is it as simple as that, or is there a big difference in another way?
Highly distinguished professor and opponent, thank you for this interesting question. You are right. The Framingham study is usually taken into account for the prevalence of tricuspid regurgitation, but we know now that the prevalence of significant tricuspid regurgitation is 0.5 in all the population. If we take into account the moderate or more regurgitation. Otherwise, we have up to 60% of cases with even mild tricuspid regurgitation. The definition of functional tricuspid regurgitation is that we have a dilatation of the annulus and a tethering of the leaflets down to the ventricle, so the leaflets cannot co-opt. So we have normal leaflets in terms of structure, all quite normal, but we have some modification in terms of annulus or in terms of tethering because the right ventricle is enlarged. So the papillary muscle go down and we have a tethering force that are higher than the closing force, and this lead a valve to be not able to co-opt, especially in the middle, in the center of the valve, so we have a regurgitation. This is now the 90% of cases of tricuspid regurgitation is now considered functional.
Okay, thank you. In chapter 4, you touch on patients with enlarged right ventricle and pulmonary hypertension. Then you just addressed the study of 541 patients where the mitral valve was actually the main problem and the tricuspid valve regurgitation was secondary to it, correct?
Yeah.
So, but all patients underwent repair of both valves, and you just showed the 6 groups. But in group A, if I understand correctly, the patients had a normal right ventricle. They did not have any pulmonary hypertension. Why were they operated in the first place? Because you compare them to the other groups and then you show all the big significant differences. But did they need surgery at all?
Yeah, you are right, distinguished opponent. But we operated these cases also because we had high grade of tricuspid regurgitation, even not in presence of pulmonary hypertension and the later right ventricle. We have probably a dilatation of the annulus, even not with the normal ventricle. So we are more aggressive into treat tricuspid regurgitation, because we say that in presence of a severe tricuspid regurgitation, you should address with surgery also tricuspid. You can think about to live and treat the moderate tricuspid regurgitation when you don't have a right ventricular dilatation or annulus dilatation. But if you have an annulus larger than 40 millimeters, you have to address also with surgery the moderate tricuspid regurgitation. This is well stated in the last guidelines.
I understand, but they received both valve repairs, also the mitral valve.
Yeah.
And that was my main question. What was the indication for the patients to have both valves repair if the tricuspid valve was diseased, like you said? But I think I'm very happy with the answer. I give the word back to the prorector. Thank you.
Thank you.
Thank you. The opposition will now be continued by Professor Meures. He's Professor Heart Valve Surgery in the Leuven University. He was member of the assessment committee, and we are also always very pleased to have members from other universities, in particular outside the Netherlands, joining us in assessing PhD candidates. Professor Meures.
Thank you. Thank you. It's my pleasure to be present here and to evaluate this PhD thesis. Dear candidate, dear Michele, it was really a pleasure to read your work. It was enlightening for many aspects in tricuspid valve pathology. I certainly specifically want to applaud you for having 2 chapters on the multi-center Italian registry. I know how difficult it is to collect data in a multi-center setting, and I think you did a great job there. My first question is regarding these 2 chapters on endocarditis of the tricuspid valve. And there are other surgeons in the panel, maybe there will be questions on repair, but let me focus, for example, on replacement. Did you see differences in long-term outcome between patients having a mechanical valve or a tissue valve in tricuspid position?
Opponent, thank you for this outstanding and interesting question. We didn't find difference, but we had few cases, because most of cases were treated with a biological valve, biological prosthesis, and just few cases with mechanical prosthesis. We did this research in other position, such as mitral position. We didn't find anyway difference. Probably we should choose the prosthesis on the basis of the lifespan of the patient and the type of patient, because if I have a drug user and I will try to repair with all my attempts, all my forces to repair the valve, because I know that the drug user has a behavior not easy to control, and so if I implant a mechanical valve, I cannot expect he going to the INR center to control his INR and so on. So probably clinical factors and also social factors of this patient has to be taken into account to choose the valve. But at the moment, we don't have, in our experience, difference between mechanical and the bioprosthesis.
Do you have any data on the patients with mechanical valves, or from your own experience? Usually, I think it's by leaflet mechanical valve types. How high do they have to set their INR to prevent thrombosis?
With tricuspid, we usually use between 2 and 3 INR, 2 and 3, not so high, but between 2 and 3. But this in my personal experience, not in our data set, because as you said before, unfortunately, retrospective big registry has some missing data. such as
Okay.
the INR used in this patient.
Okay, so I hear the majority are tissue valves. Do you think there is a difference in the long-term behavior between a porcine or a bovine pericardial valve in tricuspid position? Do you have a preference for one of the type?
No, in my experience, I use in most of cases a bovine, but actually I don't know if there is any difference in terms of type of bioprosthesis between porcine or bovine bioprosthesis in tricuspid position. We have few data, but this can be a good idea for a future challenging with this registry.
Okay. I have one final question. This is not within your thesis, but this is something for the future. You know, there are many devices in the development for treating functional tricuspid regurgitation, for example. But you know very well in the meantime that, you know, the dilatation of the annulus can be significant. There's also a huge variation between patients. Do you think that devices that address only the leaflets will ever be successful in treating those patients?
Distinguished opponent, thank you for this other interesting question. This is a big issue because I don't think, as for mitral valve, that a device addressing only leaflets can resolve a problem which is more complex. We cannot use an easier solution for a complex problem, but we have to use this technology in some cases where surgery cannot be performed, as well as for cardioband, which is used for annuloplasty, but as you can see, is an annuloplasty between two commissures. This is going to fail because it's not able to have a good durability if you use an annuloplasty between the two commissures and not including also part of the septal leaflets or septal annulus. So probably the answer to your question is that TriClip or Pascal or other device we use for addressing just leaflets in tricuspid regurgitation is at the moment is under investigation. We don't know really the results. Probably it can be a solution in isolated tricuspid regurgitation after redo, after a mitral valve surgery, or in some cases where the risk of surgery is prohibitive.
Okay, Michele, thank you very much and congratulations again. Thank you.
The opposition will now be continued by Professor Fischlein. He is Professor of Thoracic and Cardiovascular Surgery at the Paracelso University. Professor Fischlein. And he was also member of the assessment committee.
Yes, distinguished faculty, thank you for the invitation. Dear candidate, congratulations also as well for your very nice written thesis, very informative, very complex, for a very important topic, I would say, in cardiac surgery and cardiology about the so-called forgotten valve in the past. I have a question. The first question is about functional tricuspid regurgitation and isolated tricuspid regurgitation. I would like to know about your opinion or your decision when to operate and when not. It's a little bit like to be or not to be for an actor, but you know, concerning the clinical situation of the patient, when would you say operation is an advantage for the patient, or when would you say no, we should not operate concerning to the clinical situation?
Distinguished opponent, thank you for this interesting question. Today, we know that isolated tricuspid regurgitation, even function, has to be addressed when we have a severe tricuspid regurgitation with the right heart failure. So when we are in a stage 3 or 4, according to the classification by ADAD, where we have structural alteration and symptoms, when the patient is not responsive to the diuretics, because we have this patient that we can treat here in the early phase with diuretics, even endovenous diuretics, but with the time, the dilatation of the right ventricle, the failing of the right ventricle cannot be stopped with any other drug. In this case, we have to address surgically the valve before it's too late. In the last guidelines, they said when it's too late, but they didn't see us which is the parameters we have to use to say too late. The dilatation, the functioning of right ventricle, how to assess the right ventricle, only with TAPSE or also with magnetic resonance. What about the liver function? Because in most of these patients, we have an abnormal liver function. In this case, probably, we are not so sure that solving tricuspid can solve the problem of liver. So a multidisciplinary team is helpful in this case to understand which is the stage of cardiac cirrhosis. In the old fashion said cardiac cirrhosis. I have some patient in this way, and I'm not so sure that surgery can solve this problem. Probably in this patient, as I said before, technology can help us to be less invasive and to try to do something. But we have to understand now how to define too late and how to prevent, to be earlier, to operate earlier in the isolated tricuspid regurgitation. Surely, when we have massive, torrential, or severe regurgitation of the tricuspid, we should address this as soon as possible. In case of moderate tricuspid regurgitation, isolated, we cannot use dilatation of annulus as only parameters to decide if we have to operate or not. Tricuspid regurgitation is a good challenge for us for the future.
I think it would be an interesting study for the future to define the parameters, when to operate or when not. So that would be important. My second question is about endocarditis. Since you wrote in your thesis that there was no difference between repair and replacement, what is your decision actually in those patients? What would you prefer actually as a technique, surgical technique?
Distinguished opponent, as I said before, probably I should take into account all the patient, not only the tricuspid. The patient, and I have to investigate what is the behavior of the patient, because in an intravenous transducer, I try to repair the valve, even in presence of destroyed valve. I try to use autologous pericardium, so autologous pericardium to reconstruct the valve and to use some new techniques described to repair. In other cases, probably when we have a destruction of the annulus with abscess, probably we must use a prosthesis. However, my preferred choice is a tricuspid valve repair, because we try to not put inside other material, and we know that this can lead to recurrence in the early period. So this is a difficult field when we can move.
Would you actually do, because you say a repair, a devegaplastic, a suture technique as well, since you wrote about good results from Professor Carlo Fiori after 5 years. But I don't know if this annuloplasty is stable enough to do a correction in these cases for repair. So would you do, what would you do? Divegaplastic?
Oh, it's depending on what I find. If I find only a vegetation, probably I can just, personally, I use always the annuloplasty.
Okay.
Because
why are you doing this actually? I would do so as well, but why would you do an annuloplasty with a ring, for example?
Yeah, for a ring, I use a flexible ring, and I use to remove the vegetation, and I use a patch. This is, I did not have so much cases because, as you see, we had 157 in more than 20 years, in more than 12. So I have no such experience, but in a few cases I performed. I used to remove the vegetation, to put the patch if the base was larger, or if I see that the valve was infected so much, and then I put a ring, possible a flexible ring, because my school, in my school we use preferably the flexible ring, and this at the moment the 2 cases I performed are still alive and in good condition, but they were not intravenous drug user.
Okay, thank you very much. I give back to the prorector.
Thank you. The opposition will now be continued by Professor Parolari. He is a professor in cardiovascular surgery from the University of Milan. Professor Parolari.
Good morning, everyone. First of all, dear candidate, dear Michele, first of all, let me say that I know you since many, many years, and I've been working with you in the context of the Italian Society of Cardiac Surgery. And in these years, I've been able to appreciate how a hard worker you are and a fine investigator you are. Having said that, my first question concerns the relationship between the presence of right ventricle dysfunction and dilatation and long-term failure or mortality of the patient who usually undergo mainly mitral and tricuspid surgery. When you study the interplay between the right ventricle and the pulmonary pressure and tricuspid surgery, I have noted that the patient with abnormal right ventricles undergo more frequently replacement with respect with patients with normal right ventricles who undergo usually more frequently tricuspid repair. I would like you to comment on that.
Thank you for this question. Yes, we used to change the valve as for mitral valve function, mitral regurgitation, when the tethering gate is too deep in the ventricle, because my thoughts and our thoughts is that it's better to put inside function and a good prosthesis than perform probably failing annuloplastic in the future. Because if you have, as we saw in one of the slides, the tenting gates is one of the parameters which lead the tricuspid annuloplasty, isolated tricuspid annuloplasty, to fail in the future. So as for mitral valve, we have 2 roads to perform a mitral valve, a tricuspid valve repair, which means probably enlarge the anterior leaflets, or correct the subvalvular apparatus along with the annuloplasty, or to put inside a prosthesis. So in these cases, when we have an abnormal, very dilated, this cohort come from the Saudi Arabia, where we had a patient with severe pulmonary hypertension with very dilated ventricle and dysfunction. Probably the use of prosthesis is better for long-term durability than a tricuspid annuloplasty, which is going to fail.
My second question is concerning the fact that from functional mitral regurgitation, we know that not in all patients, the left ventricle is able to reverse its remodeling after surgery. If the same applies also to tricuspid surgery and to right ventricle, when do you think that is the cutoff or the best timing to work on the tricuspid to avoid the fact that the reverse remodeling may not occur?
Thank you for this other interesting question. The problem is discussed before, is that we don't have today. We don't have such parameters, but in our experience, in our studies, we investigated the reverse remodeling according to the right ventricular situation at the operation, and we saw that when we had patient with delayed and dysfunctioning ventricle at the time, so before, so above 42 millimeters of basal diameter or TAPS below 16, we had difficult to have a reverse remodeling in the future. So probably we have to investigate a prophylactic tricuspid annuloplasty in patients. So we have to arrive at surgery before the time before it's too late. But as I said before with Professor Faschlin, we don't know now how to define when it's too late. And we are, this is the future challenging for people as me that they are interested to investigate in tricuspid regurgitation, even functional or organic one.
Yes, but not concerning too late. It's when do you think it's the exact timing?
Yeah, in case of when we operate the mitral valve, surely we have to operate tricuspid regurgitation even less than severe when we have a dilatation. In one of paper I performed with Professor Carlo Fiori, we found even 35 millimeters of the annulus when we have a moderate or less tricuspid regurgitation at the time of mitral valve surgery. This is leading to a failure in the future. So probably we should understand really which is the cutoff of the annulus, of the tending gates, of the right ventricle, the pulmonary hypertension, to have a reverse remodeling after surgery. So we have to build a predictive model to understand which patient is useful to be aggressive at the time of mitral valve surgery.
Thank you and congratulations again.
Thank you.
The opposition will now be continued by Professor Mokhtar. He is professor in cardiothoracic surgery at this university. Professor Mokhtar.
Thank you, Mr. Prorector. Mr. Candidate, I read your chapter 5 and especially the limitations in the study. And you were talking about obvious variability across centers. Do you agree that in the future, also in Italy, but in Europe, there has to be established endocarditis teams to address these problems? But because there are more younger patients with intravenous drug abuse, and there are more, the prevalence of intracardiac devices on the right side also increases. So studies in the future might be better done by a team. So let's say better recommendation levels can be given class 2A or evidence levels class B or C. What's your comment on it?
Highly distinguished opponent, thank you. I strongly believe in fact, Endocarditis team, because surgery is not the only chance we have. It is not the only tool. Probably is one of these. Infective endocarditis of tricuspid is very responsive to the antibiotics. In fact, surgery accounts only for 10 to 20% of cases. Even in case of surgery, collaboration with infective disease experts or with cardiologists to understand before the operating theater what we have to do to this valve, I think is interesting, is important for the outcome patient. Moreover, probably we have to enroll in this multidisciplinary team also a psychological expert and some sociological expert that accompany the patient after surgery, especially if is an intravenous drug user, to give up the addiction. Otherwise, his fate is independent by surgery. Surgery is, in my opinion, became just cosmetic action, because patient is able to leave the hospital and to try to use again the drug, and we have again a tricuspid valve which with a higher, in this case, in most of cases, probably surgeon is not the name to do again surgery. So we have to trace the roadmap for our patient. In case of patient with leads, pacemaker leads, is interesting because in 20 years we passed from 6% of cases to 40% of cases. This is why, because we use so many pacemaker, ICD, and other leads, CCM, and so on. And so we have to take into account rightly when we put a pacemaker that we can have this complication in the future. So we have to be sure that the patient deserves this pacemaker leads.
Yeah, thank you. But I have asked this because there are new techniques coming in collaboration. For example, interventional cardiologists using the Angelvax to remove vegetations and so on. And this might be another step by not refusing patients, intravenous drug abusers, to give them a chance, because refusal of drug abusers is an ethical question. Some surgeons or cardiologists say, you don't have to operate on these patients. That's unethical because they will die on complications and so on. What's your comment on it?
Thank you. I saw that in some country, the Angelvax is used to remove the vegetation and to treat the patient, an intravenous drug user. Then the patient is accompanied on a roadmap to give up. And then when you are sure that he give up, if you have tricuspid regurgitation, you treat surgically this case. So probably this is another good step to not refuse patient of this subset. Ethically, I do not agree to refuse any patient, but this depends on also the system, the heart system. In the United States, I know that these patients are not usually treated because of the type of heart system, which is different from our systems in Europe.
Thank you for your answer.
The opposition will be continued by Professor Carlo Fiori. He is a retired professor in cardiothoracic surgery from Catania. Professor Carlo Fiori.
Dear candidate, first of all, I want to congratulate with you for your excellent thesis and your brilliant presentation. In your network analysis, you demonstrated that surgery with a device, ring or band, is better than suture annuloplasty. But also you demonstrate that it seems that the results with rigid ring, or so-called rigid ring, are more durable than results with a flexible ring. Which are the causes in your mind? What do you think? Which is the reasons?
Distinguished opponent, thank you very much indeed for this question. We have to take we have to think that network meta-analysis is just a statistical strategy to pool all together data from different studies, from different surgeons. So we have a lot of limitation. It's just to give a picture and to generate an idea to then we have to study with normal clinical trial, or at least with very large multi-center observational study to understand if really there is a difference between rigid and flexible. There are different meta-analysis which compare. Someone says that rigid is too much rigid, so it's not cannot contract with the annulus during the cardiac cycle. And there are some descents of rigid ring. Some others says that flexible ring is probably too flexible to fix for the time, over time, the problem of the dilatation of the annulus. In my belief, I think that probably is more due to the surgical technique than to the nature of the ring. In fact, when we use a band, in most of cases, I saw in most of studies that they put the band between the two commissures, anteroseptal and posteroseptal commissures, and the rigid ring is put on the annulus. But in our experience, we put the band, even flexible, on the septal, for mid part of the septal portion on the annulus, so as for a rigid ring. So probably, and we had good results with flexible rings. So probably more than the nature of ring, flexible or rigid, is the reason is to search in the technique used to put the rigid or the flexible band.
Yes, I agree with you, because often problems are related to the specific surgical technique that is used. Another question. We know from not recent studies, but there was since many years the idea that the mitral valve, when you have a secondary mitral regurgitation, is a valve that has some mechanism of adaptation to the regurgitation. So the mitral valve changes completely the thickness, the surface, and the cords as well becomes longer or thicker or retracted. So there is a sort of adaptation. And this changes the idea of secondary regurgitation in presence of a normal valve, because the valve is not normal. There is anything similar to the tricuspid functional tricuspidation regurgitation, because it seems strange that this valve has no the same mechanism that the sister valve in the left side.
Distinguished opponent, thank you. This is an interesting topic. I say that when we have a normal leaflets, we can have a functional tricuspidation. This is not really true always, because, as you said before, for mitral regurgitation, we understood, thanks to a group by Boston University, that there is something like an adaptation or maladaptation response to the stimuli, the stretch stimuli, also in case of functional mitral regurgitation. In fact, I found when I read about mitral function mitral regurgitation, where we have no normal leaflets, I read also a paper by the same group demonstrating that we have some changing, some histological changing in apparently normal valve, but it is not normal. When we have a dilatation of ventricle, a great tethering, valve is under stress, and the response to this stress is to change morphologically. And how to change? Not only flattening the annulus, not only dilating the annulus, but also changing the collagen entity of the different layers. So we have a mover from atrialis to spongiosa to fibrosa. We have an accumulation of collagen in the ring portion of the leaflets and the free edge portion of the leaflets. So probably we have to understand that also for tricuspid regurgitation, leaflets are not only bystander as for mitral tricuspidation. And this has to change the paradigm also in the tricuspid treatment. So probably addressing just only the annulus is not enough. We have to change, probably we have to, because the leaflets became more stiffer, more thicker. And so probably we have to enlarge the anterior leaflets, for example, in order to reach a good coaptation and to have a good result for long term.
Thank you, Michele, and again, congratulations.
The opposition will now be continued by Professor Gorgels. He is Professor in Transmural Cardiology. Professor.
Yes, thank you very much, Mr. Prorector. Dear candidate, as a cardiologist, I'm also happy to take part of this ceremony, and I first like to congratulate you with impressive work on a very important topic. And the right ventricle tricuspid valve are neglected issues actually for a very long time, and I've seen cases after mitral valve surgery and other surgery who are doing worse because of right ventricular failure and tricuspid regurgitation on the long term. And you found actually two important predictors actually related to worse outcomes in tricuspid regurgitation. That is the right ventricle, with whether this is remodeled, and pulmonary hypertension. I have questions about this. You are also cardiologists, as I understand. And what is we know that in pulmonary hypertension, you get remodeling of the pulmonary vascular bed. And wouldn't it be important to see whether the pulmonary hypertension is reversible before, but also so shortly after surgery to predict a short and long-term outcome in these patients? What's your thoughts about that?
Highly distinguished opponent, thank you very much. This is very interesting also for me, as you understand. I am also a cardiologist, and so I take care about some point which are not only surgical point. I think so. Probably right catheterism can be important. When we found pulmonary hypertension for two reasons. One, because we know that with the echocardiographic machine, we cannot have really the pulmonary hypertension, but just a possibility on the basis of the velocity across the tricuspid valve. We can understand if there is a pulmonary hypertension or not, but we have to do a right catheterism to understand really if we are in presence of high hypertension, high pulmonary hypertension. Moreover, because as you said before, probably too late can be when we have irreversible right ventricular resistance. So in this case, the problem is not left side and the right side. So we solve the mitral valve, we solve the tricuspid valve, we solve the problem at the pulmonary field, vascular bed. The problem now is in the vascular bed. So probably in this case, we cannot change anything if we have already a fixed resistance of pulmonary pressure.
But there's still place for a right heart catheterization to look for reversibility. That's what's your opinion about that?
This is a very difficult question because routinely it's not easy to have a right heart catheterization by cardiologists. But we have to try in some cases.
Michele Di Mauro. The time appointed for defending your thesis has now passed. The degree committee will now withdraw to discuss the quality of your thesis and your defense. I request that you and your company await the results of our deliberations and our return in this room.
Ci dobbiamo rimettere le maschere? Poi dopo magari ce le togliamo, non lo so.
Michele Di Mauro, the degree committee here present has assessed the quality of your thesis and your defense. In view of its positive verdict and taking into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. Professor Lorusso is authorized to confer upon you this academic distinction in accordance with Dutch university custom. I invite your supervisor to now take the floor.
Dear Michele, do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent, and responsible?
Yes, I did.
By authority vested in us by law and in conformity with the decision of the committee here present, I hereby confer upon you, Michele Di Mauro, the degree of doctor and grant you all rights attached by custom and law. And as evidence of this, I now present you with a degree certificate signed by the rector, the secretary, and the other members of the committee, and affixed with the official seal of the university. Be careful. A lot of work. Eh? So, we got it. So, dear Michele, I can't express how immense is my pleasure being here with you, celebrating your scientific achievement in an official ceremony, and particularly conferring you the PhD title. I personally couldn't see anyone more eligible than you for such a recognition, since you have been spending most of your professional and scientific careers towards the search of excellence in science. Despite many obstacles and constraints, we know you have been working hard, seriously, and effectively, pursuing brilliant ideas and projects in cardiac surgery and cardiology settings. And your CV is a witness of such a constant dedication and motivation. I am therefore particularly delightful, with some emotion, I must say, to be the one having this such an opportunity. That is officially to congratulate you for the objectives you reached. Our relationship has been, I would say, a long-lasting, fruitful friendship and professional collaboration, which, at least from my side, gave me so much and will certainly continue, always based on mutual respect, in-depth discussions, idea exchange, and usually leading to successful publication, fortunately. Some of them very successful. Along the most recent years, I could count on your support also for many of other PhD fellows who had and are still experiencing and will more and more appreciate how pleasant and effective it is working with you. Having you always eager to provide support, elaborate difficult statistics, helping to reply to sometimes crazy or not understandable reviewers' comments. You are now at the podium, but you may obviously deserve to stay also at my place, I'm sure, for the extent of critical help that many fellows had from your activity, and they will achieve their PhD also to your support. You have been active also in scientific societies. Your contribution and work has been always recognized, and recently you have been appointed as the chair of a multi-center study group, which by chance was created by myself. So the destiny was already written that we had to experience other scientific initiatives together, and today is just another keystone that we could reach together. But I would like to congratulate your family and somehow take the advantage of this occasion to apologize, because I kidnapped you many times, and I kidnapped you during weekends, I mean, very late in the evening. So again, apologies. And sorry for that, but I think that you must be proud for the person you have assigned, an honest, serious, loyal, professional, and I'm sure a lovely husband and father. I would like also to congratulate Professor Carlo Fiori, who besides a lot more things, he has been a worldwide recognized pioneer in cardiac surgery. He has been also your mentor and inspiration many times. Your work on cardiac valves and other topics in cardiac surgery has been remarkable. And your thesis about tricuspid valve, a long-lasting neglected structure, which unfortunately affects so many patients, often leading to irreversible and severe disease with unfavorable outcomes. So this has been the topic of the thesis, and I'm sure the thesis gave a lot of new insight, and I think some more and better insight about the treatment and management of this patient. So Michele, your patient support to our work has been also really appreciated in Maastricht, and I would like to take the advantage of this occasion to inform you that I'm going to propose you officially to become a consultant, scientific consultant of our group. But I'm sure that your help will be precious for many other groups. So the today's ceremony is, as always, not a final achievement, but just another starting point with even more difficult and ambitious objectives ahead of us, knowing that your skill, your professionality, and knowledge will make easier to get those. So Michele, ad maiora, and great success for your clinical and scientific careers. But I wish you also great success also as a novel writer and actor on stage, suggesting you to make a big difference, however, between the scientific and teaching and the theater stage, please. In one, you will provide real science, and in the other, just fiction. So do not confuse them. But as Galileo Galilei said once, a good teaching performance is 1/4 of preparation and knowledge, and 3/4 just theater. So you are in the perfect position. So again, congratulations to you and your family and friends. Thank you.
Thank you, Roberto. Thank you.
Dear Dr. Di Mauro, also on behalf of the Board of the Deans of this university, I congratulate you with the honor you have acquired. And I must note that The Maastricht University tries to be one of the most international universities of Europe. We also want to be Maastricht claims to be the center of Europe, maybe not the universe. So we are very pleased to collaborate with you and your Italian colleagues. That's one. And two, very briefly, it's been for me a rare occasion where I meet a PhD and now a doctor who is not at the start of his career, but in the middle of his career. And I wish you on behalf of our university a very fruitful career, which undoubtedly, based on what you've already have produced, will continue to grow. Thank you very much. We will now end this ceremony. The family and friends are asked to go to the rest